Can we start? Can we start? Yes, Rakesh. Yeah, okay. Now, actually, my this sound is actually coming there, and I'm getting an echo. I will make it right. Okay, fine, fine, fine. Shall I start? Okay, dear viewers, today I'm going to share you the 2024 INI SSD recall. Whatever our previous subscribers shared me, and they told the possible questions. We are going to discuss that. They had given hints of the various questions. Okay, so let us see the various questions and the probable answers. So the one question was on ideal size of nipple and areola. So when you talk about nipple areolar complex, the nipple areolar complex reconstruction can be following a breast cancer mastectomy, and NAC reconstruction is the last component of the breast reconstruction. Other indications which require nipple areolar reconstruction are due to trauma, when there is a burn and the nipple areolar complex destruction, when there is a nipple loss followed by reduction mammoplasty. What we mean is when we're doing a reduction mammoplasty, we take the nipple areolar complex based on as a flap based on an inferior pedicle or a superior pedicle, and we shift it to some other place. Then we resect some amount of breast. So while raising it as a flap, the nipple area complex can be destroyed. So that is also an indication for the reconstruction of the NAC. And of course, the congenital absence of breast amastia or athelia. So, like I previously told, NAC reconstruction is the final step in the breast restoration procedure. It is usually performed only after optimal breast symmetry is obtained. Nipple and areola are reconstructed separately. Maintaining nipple projection is the most or the greatest challenge in a nipple areola complex reconstruction. Areola is usually reconstructed with pigmented skin grafts or even tattoos. So the question says like what is the ideal position of the nipple? So I will tell you that the nipple projects approximately 5 to 10 mm, like 1 centimeter. So the normal nipple projection is 5 mm to 10 mm. On an average, the areolar diameter is said to be 4.2 to 4.5 centimeters in diameter. And roughly speaking, the nipple area complex is generally suited as the prominence of the breast mount. But objectively speaking, it is 22 to 24 centimeters from the sternal notch or at the level of the mid-humerus of that particular person. In unilateral cases, it is actually easy to reconstruct the NAC because we can match from the contralateral side. These anatomical landmarks and objective surface markings come into hand when we are going for a bilateral reconstruction, in which case the breast prominence, breast meridian, inframammary and the midline of the chest is considered to fix the nipple area complex. And also an additional factor that is usually performed after 3 to 6 months after the breast reconstruction. This is from Nelligan. The mean diameter is 4 centimeters. The average nipple diameter is 1.3 centimeters. Mind you, this is the nipple diameter, not the areolar diameter. The average nipple projection, like in the Graben snip, it is 0.9 centimeters. And this one is the average nipple areola, and the areola breast proportion, it is approximately 1.3. It can be asked in future questions. Matthews and Nair classification, type 1 plus type 4 is what? So that was the question. Based on the anatomical relationship between the muscle and its vascular pedicles, Matthews and Nair described the classification. What are the factors we took? One, what was the regional source of the pedicle? What was the number and the size of the pedicle, the location of the pedicle with respect to the muscle's origin and the insertion, and the angiographic patterns of the intramuscular vessels. So according to the Mathis and Nahai, type 1 muscle means there is one vascular pedicle or one dominant vascular pedicle. Type 2 means there is one dominant pedicle and one minor pedicle. Type 3 means there are two dominant pedicles. Type 4 means there are segmental vascular pedicles. Type 5 means there is a one dominant pedicle and multiple secondary segmented pedicles. So our question was type 1 plus type 4. So here you can see type 1 means one vascular pedicle and type 4 means segmental vascular pedicle. So 1 plus 4, as the number also says, it's 5. So type 5 has one dominant pedicle and multiple secondary segmental pedicles. Let us see the various examples for this. Type 1 dominant pedicle. These are the various muscles. It is given in the Milligan book. What I would like to say in this exam, the options I think were tensor fascial lata, vastus lateralis. So both of these are type 1 vascular patterns. You can also see the hand abductor digiti minimi, abductor pollicis muscle is a type 1 muscle. Also, gastrocnemius, very important muscle, which is used as a flap and coverage of the knee, upper one third of the tibia, and the lower third of the thigh, is also a type 1 pattern. So let me summarize: vastus lateralis, tensor fascia lata, gastrocnemius, abductor digiti minimi, and abductor pollicis in the hand. Type 2 means there is a larger dominant pedicle which can sustain the circulation of the muscle on elevation when the minor muscle pedicles are divided. Most common pattern of circulation observed in human beings is a type 2 pattern. Again, lot of muscles are given here. You remember the abductor digiti minimi from the foot and the abductor hallucis of the foot are type 2 vascular patterns. Also, the peroneus longus and the peroneus brevis, the gracilis in the thigh. These are all important muscles which is used as a flap. If you see in the thigh, rectus femoris and the vastus medialis are type 2 flaps, whereas the tensor fascial lata and the vastus lateralis are the type 1, The rectus femoris and the vastus medialis are type 2, and even the trapezius and the triceps muscles are type 2 muscles. Type 3 muscles possess two large vascular pedicles. Rectus abdominis is an important example. Also, the gluteus maximus and temporalis muscle are other two important examples. Okay, they can be located on the opposite side of the muscle or the same side of the muscle. Division of one pedicle during the elevation will allow the entire muscle to survive. Even if one pedicle is divided, it will survive on the other pedicle. Therefore, the advantage is it also allows us to split the muscle. Type 4 muscles are secondary, segmental vascular pedicles are present. It enters along the course of the belly. Each pedicle provides circulation to a particular segment of muscle. Here, the important thing is when you divide two or more of the segmental pedicles, the distal necrosis of the flap is more common. Type 4, you can see the sartorius is an important muscle which is used as a flap, and flexor hallucis longus also is an important muscle which is a type 4 muscle. Type 5 muscles are supplied by a single dominant pedicle and multiple secondary segmental pedicles. So these muscles have the secondary segmental pedicles near the origin and the large dominant pedicle near the insertion. Once again, I'll repeat, it has the secondary segmental pedicles near the origin and the large dominant pedicle near the insertion. The internal vasculature can be either based on the dominant pedicle or the multiple secondary segmental pedicles. So the basic examples are latissimus dorsi and pectoralis major. Also the fibula and the internal oblique are good examples for type 5 muscles. Expandable facial nerve used for grafting. I think what they have mentioned is which branch of the facial nerve is expendable when it is used for a cross facial nerve grafting. Okay, so let us see the anatomy of the nerves or the facial nerves. The facial nerve extratemporal part, it exits the skull base, medial to the tympanomastoid and lateral to the styloid process. It is between the styloid process and the posterior belly of the digastric muscle. The tragus pointer points to the facial nerve, which is 1 centimeter deep and just infero-medially. The branches which it gives while winding around the ear robe or branches to the stylohyoid, posterior belly of the digastric, occipitalis, and auricularis muscle. The facial nerve in the face preauricularly enters the parotid gland. In the parotid gland, it gives 5 branches. It is told usually as acronym to Zanzibar in motor car. So, temporal branch, buccal branch, to zygomatic branch, buccal branch, marginal mandibular nerve, and the cervical. These are the 5 branches. But it has been seen that first 2 trunks come, like temporofacial superiorly and the cervicofacial inferiorly, then it divides into the multiple branches. Okay, when it exits the parotid, it runs deep to the SPAC system. So here you can see the temporofacial and the cervicofacial branches, and you can see like these are the temporal branch, zygomatic branch, okay, the buccal branch, the marginal branch, and the cervical branch. Here you can see the 4 the buccal branches, multiple buccal branches are coming here, and multiple, the third branch is the zygomatic branch. So the temporal division courses in the Pitangis line, which is told as a point 0.5 centimeters inferior to the tragus to a point 1.5 centimeters superior to the lentil extent of the eyebrow. So Pitangis line is the temporal division of the facial nerve. After exiting the parotid, this particular nerve travels within the parotid of the fascia, remains in this plane as they reach the zygomatic arch and crosses more superficially under the superficial temporal fascia. The zygomatic and buccal division, 1 to 3 zygomatic branches exist. Zygomatic and the buccal branches run in close approximation as they exit the parotid. 10% of the lower zygomatic branch joins the buccal branch as a zygomatico-buccal plexus. The buccal branch runs in close proximity to the parotid branch. Here, an important point is the Zucker's point. The zygomatico-buccal branch that innervates the zygomatic major is found at the midpoint of a line drawn from the root of the helix to the oral commissure. Root of the helix to the oral commissure. The other line from the tragus to the lateral eyebrow is the Pitangis line. This is the root of the helix to the oral commissure. This is the Zucker's point. Midpoint of this is the Zucker point. The branch to the zygomaticus major will be found within 2 to 2.3 mm of this location. It is the main donor for the cross facial nerve grafting. So zygomatico-buccal branch is the can be spared or the expendable for the cross facial nerve grafting. That is the answer for the question. Then comes our marginal mandibular branch, which runs as a 2 or 4 branches. After descent from the parotid, it goes below the body of the mandible, deep to the platysma, turns to travel superiorly across the inferior border of the mandible to innervate the target musculature. Cervical branch, only one cervical branch is there, which exits the parotid anterior to the angle of the mandible. It does not divide until it passes inferior to the mandibular border. It innervates the platysma from the under surface at the junction of its cranial 1/3 and the middle third. So this is a picture showing that how the cross facial nerve grafting is done. This is the sural nerve graft. So when there is a facial nerve palsy and there is a cut injury wherein the proximal stump is not found, the distal stump is found, you can for a symmetric smile and symmetric blinking choose a donor, zygomatico donor from the normal side. Keep a nerve graft. So if it's for the temporal branches, keep a nerve graft in the supraorbital area. If it is for the smile branch, then keep it in the upper lip area near the piriform overture. Okay, and here you can see the anastomosis or cooptation of the graft from the zygomaticobuccal branch to the recipient zygomaticobuccal branch. Okay, so the cross-facial nerve grafting is usually done in unilateral palsy, and there is a normal contralateral facial function within 6 to 12 months of injury. Hypogastric flap blood supply is by. Two flaps are very important. The groin flap and the hypogastric flap are the workhorse flaps for the hand reconstruction. So this is a picture showing the groin flap whose vessel, the pedicle comes from the superficial circumflex iliac artery, and the hypogastric or the short flap whose pedicle is based upon the superficial inferior epigastric artery. Let us first see about the groin flap. Okay, it is a workhorse of hand coverage, like we previously told. The flap was the first axial pattern flap described. It is also the first flap transferred microsurgically. The blood supply is based on the superficial circumflex iliac artery. It exits the femoral vessels in the groin, runs approximately 2 centimeters below and parallel to the inguinal ligament. The flap can be taken beyond the ASIS also, in which case it is radical. Up to the ASIS, the flap is an axial pattern flap based on the named vessel, superficial circumflex iliac vessel. Distal to it, it is a random pattern flap, hence it can be radically thinned. The proximal portion can be tubed, and the pedicle groin is usually used to cover dorsum hand, forearm, first web space, etc. The hypogastric flap is basically based on the superficial inferior epigastric artery. It comes from the femoral artery. So the base is just based over the femoral artery proximal to the ipsilateral inguinal ligament. Okay, the width is usually 7 to 8 centimeters. Most of the flaps reach up to the umbilicus, 16 to 18 centimeters long. Proximally, the flap is raised at the level of the deep fascia, and it is a little bit bulkier. Distally, it is raised just superficial to the scarpa fascia, and it can be thin. The donor defect is primarily closed, and the flap is routinely divided after 3 weeks. What is the gastrocnemius flap limitation? This was the question. I don't know the options. Let us see about the gastroc flap. Gastroc muscle is the most superficial muscle in the posterior calf. It has a medial and the lateral head, and it forms the distal boundary of the popliteal crease. Each head can be used as a separate muscle flap or a musculocutaneous flap. The medial head originates from the medial condyle of the femur. The lateral head originates from the lateral condyle of the femur. Both the heads combine and attach through the Achilles tendon, which is also attached by the soleus muscle to the calcaneum. And the main action which it causes is the plantar flexion of the foot. Either or both the heads are expendable because the soleus is remain. It is a type 1 muscle flap. Okay. Here you can see the gastrocnemius button. Below the gastroc, you get the soleus, and between the gastroc and the soleus, you get the plantaris tendon. So, it is a type 1 circulation flap. The medial muscle is supplied with the medial sural artery. The lateral muscle is supplied with the lateral sural artery. It usually covers the upper 1/3 of the tibia, suprapatellar region of the thigh, and the knee region. It doesn't cover the middle 1/3 of the leg. So, that is the limitation of the gastrocnemius flap. And the motor innervation is by the posterior tibial nerve, and the sensation to the skin supplying the gastroc muscle is medial head is by the subvenous nerve, and the lateral head is by the sural nerve. What is the sequence of sensation returned in an SST? So when the skin is grafted, the skin appendages and the functional structures like the hair follicle, sweat gland, and the dermal nerves can be transferred if the skin is a thick split thickness grafting or a full thickness graft. Thin split thickness skin graft will not allow the transfer of hair or any other adnexal glands, and therefore in a STSG hair doesn't grow. Full thickness and the composite graft will show hair growth within 2 to 3 months after grafting. Nerves regrow into the skin graft by using the basal lamina infrastructure of the degenerated blood vessels and also the Schwann cells of the donor nerves to grow. Patient reports abnormal sensation like hypersensitivity pain up to 1 year, and the patients regain the sensitivity of the graft area after 1 year, but the result is not completely normal. The same neural connection to the sweat glands will reactivate their function up to 3 months after grafting. So initial 3 months you have to apply coconut oil or a moisturizer to prevent the skin graft from getting cracked. The sensory recovery to the skin graft follows a random pattern of innervation in which perception of the pain returns first. It is followed by the sense of touch and then the temperature. So this answers pain first, touch second, then the temperature. Transfeminine surgery. What are the surgeries which compose the transfeminine surgery? To start with, what is gender dysphoria? Gender dysphoria is an incongruence between one's experienced gender and assigned gender. Gender dysphoria patients or the gender dysphoria people have a normal anatomy and a hormonal physiology. They form at least 0.6% of the population. Let us first of all elaborate or see the various terminologies. Gender means the internal sense of a man or a woman defined by the cultural norms. Cisgender means the patient's gender identity matches with the anatomical sex. If the gender identity matches with the anatomical sex, it is called a cisgender. If it doesn't match, it is called as a transgender. Sex means the physical anatomy assigned at birth. Gender dysphoria means incongruence between the gender identity and the physical sex, resulting in functional impairment. In disorders of sexual development, the reproductive organs in the genitals do not develop as expected, and therefore the patient may or may not experience gender dysphoria. Sexual orientation is the emotional, sexual, and the romantic attraction one has with other people. Gender affirmation surgery is the procedure done to align a patient's body and the features with the gender identity. Previously, it was called as sex reassignment surgery or the SRS. Now it is called as the gender affirming surgery. Trans feminine patient means the patient was a male or assigned as a male but identifies mentally as a female. Trans masculine patients means the patient is birth assigned as a female, but she identifies herself as a male. So these are the basic terminologies which might be asked in the MCQs. Also, there are new terminologies like agender, wherein the people feel they don't have gender. Bigender, they feel they are both male and female. Gender fluid, wherein their gender changes from time to time. And non-binary, wherein they don't identify as any gender. So while management of gender dysphoria patients, the timeline of care is, first of all, they have to undergo mental counseling. Only the psychiatrist decides whether the patient is having a gender dysphoric disorder, after which they are given hormonal therapy, and lastly, the gender affirming surgery is done for the patients who desire it. WPATH criteria is usually used for diagnosing a patient with a gender dysphoric disorder. What is the WPATH? WPATH is a World Professional Association for Transgender Health. It is a group of International Society of Transgender Patients, Healthcare Providers, and Advocates. They issue the standard of care document to define the best practices so that we can prevent patient harm and regret. Patient should be basically more than 18 years to give a consent to do a gender reassignment or the gender affirmation surgery. The same gender dysphoria disorder also may come in children and adolescents. If it come in pre-adolescent children, it is called as gender identity disorder of childhood. But what happens is 60% or more of these children desist or return to the original gender itself. But if it persists and the patient goes into adolescence, it is called the adolescent gender dysphoric disorder or the gender identity disorder. And those patients are given puberty suppression therapy. Puberty suppression therapy, gonadotropin releasing hormone agonists are given and they suppress the pulsatile stimulation of the gonads. Whereas once the adolescent, other treatment which can be given for these patients are the cross hormonal therapy once they reach 15 or 16 years. In a trans feminine patient, estrogen and spironolactone or finasteride is given. Whereas in a trans masculine patient, usually testosterone is given to change the to as a treatment for the gender dysphoria. Gender affirming surgery for trans masculine, that is, they were born as a female but identify as a male. One mastectomy through any route, either a periareolar, circumareolar, inferior pedicle mastectomy, or a double incision mastectomy with a pre-nipple graft. Second, the genital should be removed, like the internal reproductive organ, like hysterectomy should be done along with the salpingo oophorectomy, and the genital reconstruction should be done. Phalloplasty is using flap techniques like the radial forearm flap, microsurgical technique to reconstruct the phallus. Whereas the meta-iodoplasty is developing the clitoris itself into a penis. That is called as meta-iodoplasty. Transfeminine surgery. In transfeminine surgery, again, breast augmentation has to be done, orchidectomy has to be done, and vaginoplasty has to be done. The vaginoplasty can be done with the penile inversion technique, in which you do the penectomy and the same skin is kept as a vagina, or even a sigmoid colon can be used. In facial feminism surgery, you have to lower the hairline, shave the brow bone, and reset the anterior wall of the frontal sinus. You have to do a rhinoplasty to convert a male-like nose into female. Malar augmentation has to be done. You have to reduce the angle of the mandible. Also, the anus sample has to be shaved, and tracheal shave or a tracheal shave has to be done. And finally, voice surgery is performed by the ENT surgeon to bring the shrillness of the voice of the female, and by laryngoplasty. So these are the options given in the exam, and these are the various surgeries performed for transfeminine and transmasculine surgery. The laser is not used for hair removal. Diode, neodymium, NDR, and the IPO. Let us see what all are used. Laser is light amplified stimulated emission of radiation. Laser generates spatially and temporally coherent electromagnetic radiation of a fixed wavelength into precise beam of energy. Okay. So lasers consist of, there should be an energy source and that there should be a medium housed within the optical cavity. Let us see how a laser works. First of all, the electrons or the atoms in the medium are excited by giving an energy source. Then the electrons fall down by spontaneously from an excited state to a resting state. Thereby, it releases photons with a medium specific wavelengths. These photons are kept in between the highly reflective mirrors. So they keep on reflecting, and finally, after collimation and coherence, they come out as a single laser beam once a sufficient amount of energy is generated. Now, the medium in which the total thing is being done is called, it decides what the laser is being used for. Okay. The laser tissue interactions are, the laser light may be reflected, transmitted, scattered, or absorbed by any tissue. Okay, the tissue or the chromophore is the name given to the tissue which absorbs this laser light. The various chromophores in the body are hemoglobin, melanin, tattoo pigment, and the water. After absorption, these chromophores exhibit either a photothermal, photomechanical, or a photochemical reaction. Photothermal means the localized heat is produced once the laser light is absorbed into the chromophore material. Photomechanical means there are structural degradation of the chromophore. Photochemical means a new chemical compound is developed after the laser energy is absorbed into the chromophore with a different chemical properties. So now if the laser light is sitting, coming and destroying the melanin, then the darkness is gone. If it destroys the hair follicle, then the hair follicle is gone. If it destroys the, if it touches the collagen and the scar, then there is a scar rejuvenation. So this is how a laser works. So the factor which determines the wavelength of the laser is the absorption spectrum of the chromophore located within the skin. So where is this chromophore? Whether it be a tattoo pigment, whether it's a deep tattoo or superficial tattoo, whether the melanin pigment, or whether the laser is targeting the hemoglobin, where it is present actually decides the wavelength. That is why few wavelengths are used by few conditions. Few wavelengths are used for laser hair removal, few wavelengths are used for vascular lesions, and few wavelengths are used for tattoo removal, etc. The pulse width of the laser usually depends on the thermal relaxation time, which is nothing but the estimated time required for the heat to conduct away from a heated tissue. So here you can see argon, if you use an argon medium or a potassium titanyl phosphate, yellow dye or a ruby, you get a wavelength of 488, 515 up to 694. If you use the medium as alexandrite, titanium, diode, neodymium, yarn, then you get it in 700 to 1064 range. And also, if erbium, thulium, and thallium and erbium YAG, yttrium aluminum garment or carbon dioxide is used, you can see it comes in mid infrared, in the far infrared, and erbium YAG, thallium, carbon dioxide, they all target the water as the chromophore. Okay. So the depth of penetration also depends upon the wavelength. Here you can see from 595, the deep dermis is penetrated from 595 to 1064. So what are the various pulse dye laser, ruby, alexandrite, diode, and neodymium? So you all very well know the hair follicles come in the deep dermis. So these are PDL cannot be used. Ruby, alexandrite, diode, and neodymium can be used for the laser hair removal. The other options would have been the wrong answers. So here the dermal melanin is very targeted chromophore for the laser hair removal. There is a selective heating of the hair shaft melanin which destroys the stem cells within the bulbs of the hair follicle. So long pulses and longer wavelength laser lights like 650 to 1064. Here you can see 650 to 1064. So ruby, alexandrite, diode, and neodymium yarn can be used for the laser hair removal, out of which, if the skin condition of the patient, this is called the Fitzpatrick scale of the skin condition. If the skin condition of the patient is 1 to 3, alexandrite is the treatment of choice. If the skin condition of the patient is 4 to 6, then neodymium YAG is the preferred. Whatever said and done, after the laser hair treatment, epidermal cooling is a must. Excimer laser, one of the students told that excimer laser question was used, but it is used for LASIK and myopia correction. But just for a completion sake, excimer is a short term for excited dimer. Most of the excimer lasers are used are made of halide gas, noble gases. The excimer laser typically uses a combination of a noble gas. What are the noble gases? Argon, krypton, and xenon with a reactive halide like fluorine or a chlorine. So excimer laser means two different mediums are used. One is a noble gas like argon, krypton, xenon, and another is a fluorine or a chlorine. Under appropriate condition, when electrical stimulation and a high pressure is given, a pseudo molecule by combination of these two is developed. It is called as excimer, which can only exist in the ultraviolet range. So three important things: excimer lasers exist only in ultraviolet range. Excimer lasers use a combination of noble gas and halides, fluoride and chloride. Noble gases like argon, krypton, xenon, and the pseudo molecule is called as the excited dimer or excimer. In brachial plexus, most commonly injured roots. So, according to the epidemiology, in countries like Taiwan, Southeast Asia, and India, low-speed mopeds are usually associated with the post-ganglionic nerve ruptures, whereas high-speed motor vehicles, usually seen in Europe and North America, are associated with the pre-ganglionic root avulsions. Okay, and the gunshot and sharp laceration, these are the various causes. So, first of all, to understand what is a ganglion, what is a spinal root, and what is a post-ganglion part of the brachial plexus, let us see how a spinal nerve is formed. A spinal nerve arises from the ventral and the dorsal roots of the spinal cord. These are the ventral roots, these are the dorsal roots. These both unite as a spinal nerve, okay, before exiting the dural sac of the spinal cord. They run in the groove within the bony vertebra, and the dorsal root ganglion is posterior and medial to the vertebral artery. You can see posterior and medial to the vertebral artery between the anterior and the posterior tubercles of the C5 to the T1, between the anterior and the posterior tubercles of C5 to T1. So these spinal nerves then coalesce to form the trunks. C5 and C6 joins to form upper trunk. C7 gives the middle trunk. C8 and T gives the lower trunk. The trunks are found usually between the anterior and the middle scalene muscles. The trunks again split into the anterior and the posterior divisions. at A, P, A, P, A, P. So anterior and the posterior divisions. The posterior divisions of the lower trunk is quite small and they emerge inferior to the clavicle. The posterior divisions of the lower trunk usually emerge inferior to the clavicle, deep to the pectoralis minor, okay, and they form the cords. Okay, if you see the anterior division of the upper and the middle trunk form the lateral cord, the posterior divisions of the upper and the middle and the lower form the posterior cord, and the anterior division of the lower trunk forms the medial cord. This medial, posterior, and lateral are with basis to the axillary artery. Now, the axillary and the radial nerve is separable. Here you can see the lateral posterior cord. They are separable at the posterior cord deep to the pectoralis minor. The musculocutaneous nerve is usually found in the proximal arm between the coracobrachialis and the biceps brachialis, and they come from the musculocutaneous nerve usually comes from the lateral cord. Here you can see the musculocutaneous nerve is there, the median root of the median nerve is there, and musculocutaneous nerve is usually found between the coracobrachialis and the biceps brachialis. The median nerve and the ulnar nerve are usually found in the mid-distal arm deep to the brachial veins around the brachial artery. The median nerve is given by the medial root and the lateral root of the median nerve, whereas the ulnar nerve usually comes from the posterior part here. So the most common frequency of plexus injury is the pan plexus injury, C5 to T1. It forms the 50% to 70%. That is C5, C6, C7, C8, T1 all put together form the commonest injury. Okay. The brachial plexus injuries are classified by Alnott, Terzies, and Chuang. Out of which the Chuang's classification is the commonly used and most important. According to the Chuang's classification, level 1 means the injury is the preganglionic level. We showed there is the dorsal root ganglion. Level 2 means postganglionic spinal nerve level. This is the postganglionic spinal nerve level. Level 3 is preclavicular or the retroclavicular injury. Okay, it mainly contains the trunks. Whereas the level 4 is the infraclavicular injury, which mainly contains the cords. Okay, so again, preganglionic root avulsion injuries, level 1, postganglionic spinal nerve injuries, level 2, level 3, preclavicular and the retroclavicular injuries mainly contains the trunks and the divisions, and infraclavicular injuries mainly contains the cords and the terminal connections. Also, what is the common brachial plexus palsy in shoulder dystocia was asked. Erb's palsy is the commonest brachial plexus palsy. Now, obstetric brachial plexus palsy, the strongest risk factor for the obstetric palsy, nowadays it's called the pediatric birth palsy, is shoulder dystocia. Nearly 55% of the OBP has no identifiable risk factor, and high frequency of spontaneous resolution is there in most of the birth plexus palsies. But if there is a root avulsion, extraforaminal ruptures of C5, C6, and C7, then you have to operate. So various risk factors for the birth plexus palsy, just to mention: shoulder dystocia, birth weight of more than 4.5 kgs, excess fetal weight for gestational age, breech delivery, birth hypoxia, instrumental delivery. Protective factors are cesarean section and multiple gestation. So cesarean section, in fact, is a protective factor. Apert syndrome, what are the syndactyly types was the other question. Apert syndrome is also called as the acrocephalosyndactyly. It is the autosomal dominant condition. There is craniosynostosis, midfacial malformations, and extremity malformations. The basic disturbance in Apert syndrome is the cell surface receptor for fibroblast growth factor. The Apert syndactyly are classified into 3 types, namely type 1 is the obstetricians or the spade hand. Type 2 is the spoon hand. Type 3 is the rosebud or the hoop hand. In type 1 deformity, the first leg space is normal. Okay, but the next space is narrow. There is syndactyly of all these 4 fingers without the thumb involvement. This is the most common type of syndactyly in the Apert syndrome, and it is the least severe form. In type 2, they have syndactyly of all the 4 fingers, and there is also a simple syndactyly of the thumb. It is also called as the mitten or the spoon hand. The hoop or the rosebud hand is a condition in which they have a common nail bed. That is the most important factor. And here there is a tight cartilaginous fusion of the thumb along with the index, long and ring finger with a conjoined nail. But the beauty is the little finger is usually spared, and even if the syndactyly is there, it is only a simple syndactyly. The staging principle for syndactyly release in the case of Apert syndrome is thumb and the little finger bilaterally in the first year. Stage 2 separation is done for one of the central digits, either the this with space or this with space, to give a child with a four-fingered hand like this. Okay. Due to skin shortage, it is not necessary to always give a five-digit hand. So in Apert syndrome, even you can either give a four-fingered hand like this or either give a four-fingered hand like this. But first you have to remove release the syndactyly of the thumb and the little finger. And the second, either this or this is removed. So give a four-fingered hand. Neurovascular based classification of muscles. Few of the students told it's the neurovascular classification of muscles. Few of them told it's the vascular based classification of nerve injury. So, and I'm going to show you the neurovascular classification of muscles, neurovascular classification of the integument, and the nerve injury classification. All three are available in the ligand. So, according to the neurovascular anatomy of the muscle can be taken as a free functioning muscle class. So, if the motor nerve and the vessel supplies a part of the muscle, that particular segment also can be harvested as a functional unit. Okay, so that is the reason why a neurovascular anatomy of the muscles have been studied. The common muscle which is taken as a free functional muscle transfer are serratus anterior, latissimus dorsi, gracilis, and even rectus femoris. In type 1, there is a single motor nerve which divides after entering the muscle. Multiple vascular pedicles are present, which forms a continuous network. You can remove a vascularized segment of the muscle with its nerve supply in this case. So, single donor motor nerve. Here you can see the various muscles which are fitting to this type 1. This is not the Mathis Nahi. This is the neurovascular classification of the muscle. So, LD, palmaris longus, popliteus, etc. Type 2, again a single motor nerve supplies the muscle. The nerve but divides before entering the muscle. Nerve divides before entering the muscle. The classical example is deltoid, gluteus, trapezius, vastus lateralis. Type 3, multiple motor branches are derived from the same trunk. Like a gastroc, posterior tibial nerve gives the nerve to the median sural and the lateral sural. Therefore, can subdivide each muscle to separate functional units. And multiple vascular pedicles are also present. So again, you can see gastroc, sartorius, triceps, gluteus medius, minimus, vastus medialis, and vastus intermedius belongs to this type 3. Type 4 is multiple motor nerves are coming 1, 2, 3, 4 like this. Each muscle can be subdivided anatomically into several functional units. Because of the multiple often segmental neurovascular bundles, these muscles are formed developmentally by fusion of adjacent somites. Okay, usually it will be traversing the neck or a long thigh, etc. So rectus abdominis, internal oblique, and erectus spinae muscles. Multiple branches with different nerve tracts. This is a neurovascular classification for how the vessel and the nerve enters the skin. A long artery is connected to its neighbor by a true anastomosis course with the nerve. That is type 1. Type B is a chain-linked system of arteries hitchhike with the nerve. Type C is the nerve and the artery pierce the deep fascia at separate sites, and the branches of the vessel peel off to accompany the nerve as it crosses the main arterial trunk. In type D, the nerve at first courses parallel to the artery and then approaches the neighboring artery from its periphery to descend along its branches towards the main trunk. In type E, the nerve crosses the primary and the secondary arcades of the artery before coursing parallel to the vascular network. So that is the neurovascular classification of the muscle, neurovascular classification of the integument. Here then, the peripheral nerve injury is usually classified by the Apert Sedan. Okay, there are three injuries: neuropraxia, axonotomesis, and neurotomesis. Neuropraxia is a local conduction block at a discrete place along the course of the nerve. There is no well-ended degeneration, and the recovery is usually excellent. Axonotomesis is direct axonal damage. Well-ended degeneration occurs distant to the site of injury. The patient recovers, but the degree of injury is associated with scarring unless complete recovery. Type 3, the complete transection of the nerve, valerian degeneration occurs and it does not recover, and there is a total scar in continuity with no recovery. Sunderland emphasized the 5 degrees of nerve injury, and the Susan McKinnon added a sixth one. So type 1 is same in all Setten, Sunderland and McKinnon conduction block. In type 2, it is the axonal rupture without the interruption of the basal laminar tubes. In type 3 is axons and the basal laminar tubes are ruptured and some scarring is there. Type 4 is complete scar block. Type 5 is complete transection. Type 6 is a combination of 1 to 4. So here in first degree is neuropraxia, second degree is axonal vertex, here injuries recover spontaneously. Fourth and the fifth degree, the injuries never recover. Whereas third and the sixth degrees, third and the sixth degrees, there is a scar block and it partially recovers for various reasons. This is the first nerve allograft transfer done. Nerve allograft have a history. Edward Albert was reported to use the nerve allograft from in an amputated limb to bridge a 3 cm median gap by reduction of his sarcoma. He did not gain broad acceptance because immunomodulative therapy was essential while doing a nerve allograft. So to obviate the reaction, we had to give irradiation to the nerve, enzymatic treatment, detergent processing, and cryopreservation, so that we make the cells acellular while preserving the basal lamina and architecture of the nerve. Susan McKinnon applied the same concept of allografting with immunosuppression. And the good results were achieved in her study. The process to now allografts have many advantages. They are biocompatible, easy to use, does not require immunosuppression, and avoid a donor deficit. And the commonly available allograft is Avance nerve graft, which is approved by the USA. In these, when it is used for sensory, the recovery is 3+, whereas when it is used for motor, the recovery is M4+. Which is the least used area for a tissue expander? And one more question is, which is not a complication, various complications are mentioned, and pigmentation is the answer. Let us go into some of history of the tissue expander. Cordivilla applied the principles of external destruction directly to bones. That is why Cordivilla is known for external fixator and Elizarus as a godfather. Putti used the continuous and elastic forces are required to overcome resistance of the soft tissue. So he proposed the concept. Newman used the rubber balloon through an externally exposed tube with a stopcock and did an expansion for a ear defect. So here he used the external port, whereas Radovan used the concept of tissue expansion and used an internally placed port. Ostad and Rose told the physiology behind the tissue expansion. I would like to explain two important concepts: creep and stress relaxation. Creep is when there is a stretching of the material and air. What happens when there is a stretching of the material and air constant load over time? Constantly, if you keep stretching the skin, what happens with the constant load over the time? That is called as creep. Creep is of two types: mechanical creep and the biological creep. Mechanical creep is the ability to acutely stretch and increase the surface area in an immediate intraoperative expansion. Here, what happens is the fluids are pushed out of collagen. There is a dehydration of tissue. Collagen fibers are realigned in a parallel fashion. There is a microfragmentation and adjacent tissue migration. If the same thing happens chronically, it is called as the biological creep, and there is a significant gain in tissue dependent on the chronicity. There is increased fibroblasts in the collagen tissue, increased myofilaments, increased mitotic activity, and the neovascularization. Stress relaxation is preventing the tissue from retracting back into its pre-expansive form. Because of stress relaxation only, whatever expansion is achieved is being maintained. That is happening because of the formation of the new tissue. Therefore, the force required to maintain the tissue elongation decreases with time. That is called a stress relaxation. What are the various changes while using a tissue expander? Epidermis, there is increased mitotic activity, but the dermis, there is a dermal thinning. Collagen synthesis is increased fibroblasts and myofibroblasts, realignment of collagen fibers, decreased air molecule density. In the muscle, there is thinning. Functions are unchanged, but myofibrils and myofilaments become disorganized. There is increase in the size and number of mitochondria. Fat permanently decreases in cell and thickness. Fat necrosis and fibrosis can also occur, but blood There is a good proliferation of blood vessels with increase in venules and arterioles. In principle, the number of vessels are usually increased due to the vascular vessel growth factor. Surgical design, there is a high risk of complications between smoking, radiation, infection, and you should do consider an acute coverage of the defect. Therefore, it is very well used in neck, very well used in scalp, very well used in forehead, but extremities or especially legs, the tissue is not conscious. The various complications of tissue expander are seroma formation, widening of the scar, discomfort from expansion, bone resorption. If you keep it on a bony surface, most of the time you need a bony surface to keep the tissue expander. Because of the stretch of the nerve, there can be neuropraxia. Sometimes there can be excessive flabby tissue also. Major complications are hematoma infection, implant rupture, implant exposure, hydrogenic injury to the adjacent important structure, and overlying skin also can become sticking and cracked. If there is a hematoma, we have to reoperate and explant the tissue expander. Minor infections are treated with antibiotics, but if the purulent infections are present, we have to do an explantation. Implant failure can happen sometimes if there is an internal failure of the manufacturing or manufacturing defect. Okay. Therefore, always access the port at 90 degrees using a 23 gauge needle. Preventing skin damage, the skin shouldn't become too taut while expanding the tissue expander. Capillary refill should be there, blanching should not be there. And if it is too uncomfortable, patients always withdraw some amount of the saline. Next question is, what is Blauth classification used for? Blauth classification is used for a thumb hypoplasia. Okay, let us see the various Blauth classification. Type 1 is a minor thumb hypoplasia, only a smaller thumb is there. Type 2 is there is a first web space narrowing, hypoplastic thenar or intrinsic muscles, and the MCP joint instability. Type 3, the first web space narrowing is there, hypoplastic thenar muscles and MCP instability is there, along with the skeletal abnormalities are also there, and extrinsic tendon abnormalities are there. The skeletal abnormalities are in the type 3A, there is a stable CMC joint with a hypoplastic metacarpal. Whereas in the type 3B, there is an unstable CMC joint and partial metacarpal aplasia. Type 4 is a floating thumb, and that is also called as a post flotant, and type 5 is an absent thumb. Surgical treatment of thumb hypoplasia is basically dependent on what happens to the carpometacarpal joint. In milder cases like type 2 and 3A, reconstruction is focused on widening of the web space, opponent's plastic procedures to bring the thumb into opposite position, and MCP joint stabilization. Whereas in severe case, like when the CMC joint is not there properly, like 3B, 4 or 5, thumb if cannot be effectively reconstructed. In all these cases, the present miniature thumb is ablated and index polygization is the treatment of choice. The most important muscle for normal speech. Velopharyngeal port is the most important organ for the speech. It is anteriorly found by the soft palate of the velum, laterally by the lateral pharyngeal walls, and posteriorly by the posterior pharyngeal wall. Muscles of the soft palates are levator palate, tensor palate, palatoglossus, palatopharyngeus, and musculus uvulae. Out of which the levator palate is the most important for speech, and it takes origin from the petrous part of the temporal bone and from the medial aspect of the eustachian tube. You can see here, this is the eustachian tube, and the levator palate takes an origin from there. It courses anteriorly, inferiorly, medially. From the eustachian tube, anteriorly, inferiorly, medially. This is the palate, and it inserts into the palatal aponeurosis. Here you can see there is a deposition of the levator palate with the contralateral levator fibers. Okay. So contraction of this particular muscle sling found by the paired levator is the primary mechanism for the velar elevation and closure of the velopharyngeal port. Musculus uvulae is a muscle over the dorsum. It just adds bulk to the dorsal surface and contributes to the velar thing, but that's not important. Superior pharyngeal constrictor is another important muscle. It originates from the velum, that is the soft palate, pterygoid, and the pterygomandibular raphe. It inserts into the median raphe. Constriction of the superior constrictor contributes to the velopharyngeal closure by movement of the lateral walls. but the genuine movement of the velum is mainly by the levator palate. So what is the blood what is the nerve supply? The tensor veli palati is supplied by the trigeminal nerve. All other muscles are supplied other than the tensor palati. All other muscles are supplied by the pharyngeal plexus, which is found by the 9, 10, 11 nerve. The functional activity of speech is a voluntary activity controlled by the motor cortex, whereas the functional activity of the swallowing is a reflexive, involuntary activity which originates from the brainstem. What is Brachial flap used in reconstruction for? Brachial flap is basically used for a nasal reconstruction. It is a retroauricular temporal flap. Okay, it is used for reconstruction of the central portion of the nose. It requires a pedicle for transport. The skin on the posterior ear, the posterior mastoid skin can be taken over this. Here you can see the superficial temporal artery and the retroauricular artery anastomosis and form the axial pattern flap. It has an excellent matching to the texture and the color of the nose, and it is comparable to forehead flap. Okay. Here you can see how the flap is elevated. The anastomosis between the superficial temporal and the posterior auricular vessels on the skeletal side is used. Okay. And once you place the flap to the nasal defect, the division is after 3 weeks like any other pedicle flap. Also, the main advantage is after 3 weeks of division, only this part of the flap which is transferred is used. This part is again returned to the scalp. Initially, it is grafted, but after that, the graft is taken and again it is returned to the graft. So here you can see a nasal defect. Here you can see the superficial temporal artery is present in this flap. The retroauricular artery is present. This is the posterior auricular area skin which is used for the nasal. It is rotated and clockwise, and its insert is given here. And after division, a beautiful nose is seen here. Maillard and Montadan did a modification wherein they incorporated the conchal cartilage itself and also tubed the flap. So you can base this flap here. You can also take the conchal cartilage, and by taking the conchal cartilage, you can give solid cartilage support to the nose. So Maillard and Montadan modification is taking of cartilage graft and also they tubed the pedicle, which prevents the desiccation and oozing from the interior surface of the flap. The tip of the flap can be redesigned with retroauricular skin or cartilage and also subcutaneous tissue from the mastoid region. The main advantage of the Brachial flap is it doesn't give any visible scar on the face. But the disadvantage is the amount of material available for the reconstruction is very thin. Only less amount of the mastoid material is available. It is not possible to attempt a total reconstruction of the nose by this flap alone. This is the last question, wherein the Atasoy flap, Venkateswamy flap, the options which is not an option for an index finger defect, and what is the contribution of the thumb in the hand function. All these will be covered in the next few slides. Fingertip defect, the main goals are restoring the tactile gnosis by giving a good padding, preserving the length, keeping the nail bed intact, and giving a sensate fingertip. For defects less than 1 centimeter, secondary intention healing can give you good contour and a good consistency of the pulp. But if the defect is 1 to 1.5 centimeters, usually a local flap or a V-wave flap is used. For more than 1.5 to 2 centimeter defects, loco-regional, homodigital, heterodigital, or a free tissue transfer can be done. So the various options for the fingertip defect are V-wave flap, especially for the dorsal oblique amputation. It is also called as the Atasoy flap, cross finger flap, Tenar flap, reverse homodigital island flap, heterodigital island flap, dorsal metacarpal artery flap, and microvascular toe pulp transfer. Here, this is a V-wave flap. Here, you incise this flap here, you detect the subcutaneous tissue, you advance and suture. It is also called as the Atasoy V-wave advancement flap. Cross finger flap, we all very well know. The dorsum of the finger is opened as a flap. The dorsum of the finger, the flap is open, and this pedicle flap is attached with the fingertip. Over the 3 weeks, this flap attaches to this fingertip, and what happens? Reciprocal supply is developed, reversal of supply is possible, and this flap is divided after 3 weeks. Footler flap is when bilateral small V-wave flaps on either side of the fingertip is used. It is used for the volar oblique amputation. Here you can see triangles are there. Okay, it is advanced. and sutured in the midline. Fingertip flap is a neurovascular flap having a large V, even up to the proximal crease is taken. The digital nerve is usually included in the Fingertip flap. Thenar flap is again a random flap. The excess of skin in the thenar crease can be used. It can be proximally based, distally based, or as a combined. You can see the fingertip here. Here a combined flap is taken, A and B, and finally it is divided and the flap cover is given. With respect to the thumb fingertip defect, the question asks what is the percentage of the total function the thumb gives. 40% of the total hand function is given by the thumb for pinching, grasping, and opposition. Here, the reconstruction has to be done to provide an adequate length, non-painful tip, good sensation, mobility, and stability to oppose. Ulnar contact of the thumb or the key pinch and the 3-point grip is very important. And the various options which can be used are again a VY advancement. There is also a flap called as Moberg, FDMA, Neurovascular heterodigital island flap, reverse dorsal radial artery flap, and microvascular pulse flow transfer. In Moberg flap, it can be done only in the thumb because both the neurovascular bundles are taken in the flap and advanced. Some say there is IP joint contracture, but most of the time a good result is there. This cannot be done in other fingers because thumb also has a dorsal digital artery which can supply the vascularity of thumb. If you devascularize by taking this flap with both the neurovascular bundles here, the finger itself can go for necrosis. So, mobile flap is exclusively used for thumb tip deflection. FDMA, first dorsal metacarpal artery axial pattern flap, is based on the first dorsal metacarpal artery vessel, its branch, and also the dorsal distal nerves from the radial artery. Islanded flap, and it can cover the volar aspect, dorsal aspect, etc. to cover the thumb. Neurovascular island flap of Littler. Here, since thumb is a very important organ and requires the sensation, you can primarily itself take a digital artery and pediculated flap. But if you take the ulnar part of the ring finger, the ulnar nerve sensation comes. If you take the ulnar aspect of the middle finger, the ulnar side median nerve sensations of the middle finger comes. Cortical reorientation to perceive it as a thumb sensation takes a very longer time for neurovascular island flap. A toe to thumb flap. Okay, here this toe pulp tissue is taken along with the vessel, first dorsal metacarpal artery. It is transferred to the fingertips, and this is a microvascular tree flap. This is the flap called as a reverse radial foramen. Based on the superficial palmar arch, the proximal part of the radial artery is cut and it can be transferred for any thumb reconstruction procedures. This is the last question. What is the Brunner's incision used for? Brunner's incision is a zigzag incision used for exploring the flexor tendons. What we do is, usually what they say is, when the edges of this crease are joined here like a diamond, this area is called as a Littler's diamond. No incision should go longitudinally across this Littler's diamond. Okay, so the edges of the transverse creases are joined and these are opened as a zigzag incision. It reduces the flexor contracture. It gives a good skin flap viability, good access to the tendon, and also preserves the neurovascular bundle. This is called as a Brunner's incision. So when a traumatic laceration is there, you can access it like this. Otherwise, when you are opening it primarily for doing a old tendon repair, you can do it like this. When there is a trauma laceration, you can give extensions of this laceration and convert it into a zigzag extension and a Brunner's incision. Otherwise, also you connect the edge of the creases and do this Brunner's incision. Midlateral incision is also called as the Bunnell's midlateral incision. It's the dorsal to the flexion crease. It is designed with the 3 key principles. It preserves the neurovascular bundle, the neurovascular scar position. There is a neutral scar position. This scar doesn't go for contracture at all, and there is also good access to the all structures. There is another thing called as the midaxial incision, and which connects the joint axis of all the joints in the fingers, like PAP joint and the DAP joint. This particular figure shows midlateral incision, midaxial incision, and the Brunner's incision. C is the zigzag Brunner's incision. Here you can see. D is the midaxial incision. The joint axis is taken this little bit dorsal to the midlateral incision which is present on the flexural crease. Hereby I finish this class on the ionizers need class. Thank you. If there is any doubt, participants can tell. Otherwise, I am stopping. Thank you.